So the output should not be, is not in itself the goal as much as knowing what contributes to that output,
Right.
what goes into making that output happen. Good thing. And yes, I think that once you have the assessment leading you, then the technique is often secondary. It's important, but it does show you what techniques you will use from your toolkit, and what might be available. And really, it then comes down again to principle. If I need to stretch or move a tissue, I have many different techniques at my disposal. There's no one technique that I must master to do this, as long as I know what the goal of my treatment is going to be. And then I will know if I have achieved it or not. And I have my audit process to tell me if I need to change the technique. Am I succeeding or am I failing in achieving my goal? So really, it still frees you up to try different things as long as they're within the family of techniques that affect that tissue or that system. And I
Right.
think that that way you are less worried about how accurate the technique is if you're practicing it to the level of the guru that taught you, and more interested in, am I effective in actually changing the afferent input into the system? And
So,
again,
yeah.
we are often obsessed with the output. We go, oh, he can't do that. Oh, can we make him do that now? Oh, he can't do that. Oh, we have to make him do that. You go, no, the output is dependent on the input. So if there's a deficit in input, that's why he can't do it. So
I
you
mean,
have,
that is analogous to the idea that the technique is the primary important thing
that's right.
versus the assessment.
That's right.
And in the same way, if the output seemingly is the important thing. Oh, you're having pain when you squat and lift up this weight. Well, we should just teach you how to lift up this weight
Mhm.
more effectively. And in fact, that output of lifting up the weight is an output. We
That's right.
have to.
Just an output. It's nothing more. So the output should not be, is not in itself the goal as much as knowing what contributes to that output,
Right.
what goes into making that output happen.
Yeah.
It is
Because
not,
because you make an assumption that the inputs are fine. It's
yes, you,
just simply the execution that there's a problem.
that's right.
And
That's
we
somehow,
all know that the inputs involved, they're complex. That we all agree. It's all, yes, very complex
that's
thing.
right. It's
Very
very,
complex sensation. You have to feel it through your foot.
that's
You have to feel the
right.
brace. You have to breathe. But then we just say, oh, they must be doing that fine. We just need to teach them how to lift that,
That's
you
right.
know,
Nobody made a cake by baking a tin. You've got to put the mixture together and pour it into the tin. It's not going to happen any
in the
other way.
appropriate amounts.
Exactly, in the appropriate amount. If you screw up the proportions, you're not going to
The
get a cake you
inputs.
like. You're just not going to get a cake you like. So it's really quite fascinating. And I think that one aspect that is now coming on board is for instance, when I went to school, it is all about joints, muscles, what they do, can they contract. We were interested in bones. We studied that. We looked at things like impingement of the shoulder, and we wondered what did that mean.
Hmm.
And then later on, we started putting things into groups. We started looking at the knee alignment and what that meant for the meniscus and the patellar tendon problem. And initially we taped it locally, and then we started treating the whole leg to improve it. And now we have got to the point where we are looking at systems. We're going, okay, what is the presentation of tight fascials of a dysfunctional fascial system? what is the presentation of the dysfunctional neural system, adverse tension, or is the container damaged? Is the are the neural fibers damaged? Is it a process? And so, and I must say, what is interesting and fascinating now, we then went to the vestibular system, and we started getting a lot of vestibular assessments, which came on with the concussion um, um,
Mm.
the
Research.
concussion
Yeah.
rage and mania, which has been important to drive that. You know, the ocular, the vision, the vestibular. And now we start seeing the nasal, oronasal passageway. How do we maintain breathing? What is tongue ties? What is tethering? What is the jaw position for ideal breathing? Where's the ideal tongue position for breathing? So now we're looking, is there fascial tension that is linked to problems of the neck and tension of the shoulders and so on? So I think that as we bring systems on board and learn to assess them, the better the analysis will be, and we will make more effective and efficient decisions in the triaging of our patients. Because if you are not looking at the one of the things that is so important is what is the physical presentation of a system dysfunction. That is what we
Mm.
must understand. It is not knowing the dysfunction itself as its own entity. It is knowing what systems does that dysfunction represent. And then we can go back and assess these systems. So if I
Dear
have
God Almighty. Dear God. So what, you spend maybe 6-7 hours per patient to checking every
I
one of these systems? Is that
no,
what you've developed now?
no, I don't think it needs 7 hours. I think it needs
A screen.
well-known tests, yes,
Yeah.
screens of systems that arise as the most likely culprits in the syndrome and symptom presentation or the failure of ADL function. So that is really what you need, because the patient comes because of ADL failure usually, or trauma, but those are usually the two ways they come, or some disease that is known. So if we can work back and go, these are the most likely systems involved given the presentation, that's where we start. That is really the beginning of assessment. And it's really going to be, as we learn more and keep abreast with the research, we should be better at triaging these.
Mm-hmm.
Yeah.
Mm-hmm. That no, I mean that makes very good sense. As physical medicine practitioners, of course, we're always, you know, our perspective is always musculoskeletal based. If you're, really thinking it's neuromusculoskeletal based, uh, in the back of our heads, we might think, okay, there can be some type of chemical inflammatory problem here too, but I'm not directly treating it. I'm using kind of the history and how the clinical syndrome is changing to get an idea of the chemical inflammation aspect. But other than that, that's about as deep as we would go, and most of the time that's sufficient because
Yeah.
these problems usually arise from there. But then it does come down to the quality of the screen and assessment in each aspect of that. And unfortunately, at least for me, I thought my schooling and education was very, very good, but it can always be better, and it could always be honed, and it could always make a bit more sense.
Mhm.
And that's where this kind of thing comes in. So
Yeah.
if you enjoyed this conversation and want to hear more like it, then please like this video and subscribe to our channel. You can also stay up to date on our latest seminars on our social media pages on Instagram and Facebook
at IMTR seminars.